We are very fortunate to have in the room Associate Professor Anthony Byrne, an experienced respiratory physician at St Vincent's and St George's Hospitals in Sydney, Associate Professor of Medicine at UNSW and a respiratory and global health researcher as Principal Investigator on many national and international investigations, and also co-leads the multidisciplinary long COVID service at St Vincent's Hospital with Professor Stephen Foe, and also leads the tuberculosis service at the hospital. So very busy, so we're very fortunate to have him attend in person to present on long COVID, common symptoms, challenges and management options. So thank you.
Thank you. Thanks to Paul and to the organisers for inviting me along. So I'll get on with the presentation. It's compared to the last one, a more clinical presentation. I'd like to also thank, of course, Professor Stephen Foe, who's my co-lead in the clinic, and also to my my long COVID fellow, Osama, who's prepared a couple of these slides for me. So learning objectives. No, hopefully you don't have any objection to these learning objectives. To describe the 5 most common symptoms of long COVID, understand the 3 key challenges of the diagnosis, identify those at-risk populations for this condition, and also to understand the concept of treatable traits as it relates to long COVID, because I think that's a really practical way in which we approach this in our clinic and in clinical practice. And we should, of course, also recognise the limitations for evidence to treat this condition. So as we've heard and as we have lived, we know about the pandemic, and over the last 4 or 5 years, there's well over that number of COVID survivors and well over 7 million deaths. I mean, as we know, in the last couple of years, the data, both for testing and complications of COVID, has significant limitations. There pretty much isn't any. The service that we have at St Vincent's, we've been going for about 3 years now. We're one of the first multidisciplinary clinics that's medically led, and one of the longest running now. In New South Wales, I think we're the only tertiary hospital with this sort of medically led service that services adults over the age of 16. GP referred patients that have baseline examinations and investigations that include the Yorkshire COVID-19 questionnaire, chest X-ray, and a standard sort of approach to blood tests. They're triaged by our clinical nurse consultant and then allocated to either a thoracic medicine or rehabilitation arm of the clinic. But often there's crossover, and the patients that see one will often see the other, and vice versa. And we took the approach early on to do some, as a respiratory physician, to do some lung function on these patients, and we did both and have done both spirometry and oscillometry. Some will be familiar with the former but not the latter, and I'll just mention that briefly at the end because I think it's quite a useful test. So we've developed some resources through the Lung Foundation of Australia for patient resources for understanding long COVID. And this is a slide from one of the ADAPT study and looking at a population of people infected with SARS-CoV-2 in the early part of the pandemic, 2020 and 2021. And you can see there that the acute symptoms over the first month compared to beyond that, which at that time wasn't called long COVID, of course, that term came about later. But you can see the most common symptoms of fatigue, cough, shortness of breath, headache, at that time anosmia, which is sort of not as common now, and those symptoms do persist in a proportion of patients. So what is long COVID? I mean, that's an interesting question. I mean, there's immunological answers to that question, and there's sort of clinical and symptomatic answers to that question. There's over 200 symptoms that have been described in this population of people over, beyond 3 months, and it's essentially the persistence of those symptoms beyond that time that are not otherwise explained, and that's important, I think, because it means that there's some interpretation that's required to otherwise explain them. And it's difficult in some of the studies as well to get that, because if you have sort of a questionnaire, it's not necessarily teasing out that information, that clinical aspect of it. So that's important to recognise in the data as well. In terms of the immunology that's been described, there's certainly changes that are seen in humoral and cellular immunity that persist beyond 3 months, and there is some data to suggest that there's improvements over 24 months. But certainly we have patients that are in the outside that range that are still persistently unwell beyond two years. And it results in airway, vascular and nerve injury, basically, and organ dysfunction, and it leads to reduced quality of life. And those symptoms have really real impacts on social functioning and economic and professional roles in these patients. So from a respiratory perspective, some of the disease processes that have been well described, and we see these in other diseases. These are not unique to SARS-CoV-2 virus, of course, but we see in the severe spectrum lung alveolar injury and diffuse alveolar damage on autopsy. So SARS-CoV-2 destroys type 2 pneumocytes and causes inflammation, and then you have this sort of a cytokine storm and viral replication. And within the vascular system, we see thrombosis, and we see a dysfunction and damage on the alveolar level and coagulopathies. And then within the airways, we see problems there with inflammation and problems of dysfunction within the airways. So the 5 most common long COVID symptoms, and it will depend a little bit on where you go for this, but I think there's no argument about the most common symptom, which is fatigue. So it's definitely fatigue, and then the order after that, depends a bit on the study that you look at. But this concept of cognitive dysfunction, mild cognitive impairment, brain fog is real and is experienced by a large proportion of our patients. Breathlessness with or without cough is also really common, and pain, including chest pain, is really common and really important because it results in many healthcare-related episodes and emergency visits and hospitalisations with these patients with chest pain. And mental health is also, as you would expect, not uncommon in this population that are debilitated and can't work and can't function, and does result in sleep disturbance as well. So our service has been going for about 3 years. We've seen over 1,000 patients now, and the average time to review for our service is usually around 6 months to 12 months. There's a minimum of 3 months, of course, to come up with the diagnosis, and then, as you'd expect, there's a little bit of a waiting time. The average age of patients that we see is around 50, and there's a female to male predominance, which is also seen in other studies, but this is real-world experience. And at least a third of our patients are unable to work or are working in a limited capacity. And this is 6 months post. So we're seeing sort of maybe the worst of the worst perhaps, but these are very debilitated patients that haven't been able to work for a long time. And many of them have seen other specialists, multiple other specialists, and that gets, particularly in this environment, very costly and very difficult. And so that's also important to note. And so we have this approach of a multidisciplinary case conference that we do and care for these patients with physiotherapists, psychologists, nursing and rehabilitation. And it's a very complex problem. It's very difficult to do that in as a specialist, as a sole functioning, respiratory physician or cardiologist, but also in general practice. For our audience there in general practice, very difficult to manage these complex patients. Some of the challenges with the diagnosis of long COVID, and there's many. And it does seem pretty frustrating, much like this young boy with his head against the blackboard. And it sometimes feels a little bit like this tree in the forest that has fallen. If a tree falls in the forest, does it really matter? Well, it matters to the tree, and it does matter to other people. But the reason I put that up there is there was this study that got a lot of media attention, I think, last year. From Queensland. I'm not sure where it's been published. I think it probably has been published subsequently. But it was looking at comparing SARS-CoV-2 to the flu and looking at self-reported 3-option outcomes at 12 months. And, basically the conclusion of the authors were that it was the same and that there's no difference between flu and COVID. But there are some really important things to consider here. One is the vaccination rate amongst the COVID patients, which was 98%, compared to flu, which was 40%, and the adjustment for comorbidities as well as objective assessments. In larger studies that have assessed, so the veteran study in the States looked at hundreds of thousands of people that were admitted to hospital, so admittedly more severe disease, but comparing it also to influenza. And an important finding of that study was that there was an increased 30-day mortality with COVID compared to influenza. So if there is any attrition, then you won't capture that in your survey. And that's obviously a significant hazard ratio there for that particular outcome. The other important thing that's not considered by this study is the healthcare-related presentations. And it has been seen in this study and others that these long COVID patients present to doctors frequently, knowingly or unknowingly, but they present to GPs in emergency, which is really important and a really important difference comparing it to flu. So that brings us to the three key challenges. There's more, but this is just three to be aware of, I think, as it relates to long COVID. And the first is that the diagnosis is not considered by either the patient or the doctor evaluating them. And how could that be? Well, a patient comes to see you with fatigue or with chest pain or breathlessness, and it's not recognised that they actually had COVID 3 months ago or 6 months ago, because they didn't test and didn't know about that diagnosis. So that's an important challenge. The next is that there's no single diagnostic test for this condition. As we saw from the from the definition from the WHO and from others, it's a little bit vague, and it requires some thought to what's explainable and what's not explainable by current symptoms. And then the third challenge that we see a lot of is that these patients are often comorbid and very complex, and 99% of them that think they have long COVID have long COVID. So the diagnosis is not in question. What's in question is how much blame, if you like, to allocate to long COVID and how much to allocate to their poorly controlled diabetes or their chronic pain syndrome or their sleep apnea that's undiagnosed, et cetera, et cetera. So this is some of the complexity of managing these patients. Risk factors, and I was having a chat to John just before this presentation, and his team have come up with a risk calculator, which seems like a really good resource, and it incorporates some of these risk factors that have been identified for long COVID. So one particularly important for this conference is being unvaccinated, of course, or also being under-vaccinated, because a lot of my patients, and I'm sure yours as well, will say, well, I've had 3 vaccines. But then the next question is, well, when was your last vaccine? And it was 3 years ago. So obviously being under-vaccinated or unvaccinated is really important and is a clear modifiable risk factor. The severity of the acute COVID infection is really important. And we saw that, and you see that in the data. In 2020, as was mentioned by our last presenter, patients were being admitted to hospital frequently, like 10%, 20% had severe disease, 1% mortality rate. So those severe episodes of acute COVID are fortunately less common now, but they're still occurring. I mean, I've got a patient at Vinnie's right now that's intubated after 2 weeks of COVID-19. He's about 3 weeks post-infection. He got that on a cruise ship. And he's under-vaccinated and has many risk factors for severe COVID. Older age, female gender, certain comorbid conditions, including hypertension, diabetes, being immunosuppressed. We see this a lot in Vinnie's at a transplant setting, and I'm sure you've seen it as well with these patients that keep testing positive. They have problems in clearing the virus because of their compromised state. And then there's these other ones which are really interesting in terms of the stress that the person had at the time of their acute infection. That's a factor. Low self-esteem, interestingly, has also come out as a factor. So these are interesting risk factors, some modifiable, some not. This concept of treatable trait's been around for a little while now, at least 10 years. Very useful for complex chronic conditions where there's not a lot of evidence, and that includes long COVID, obviously. So with my co-authors here, including Bruce Brew and Peter Gibson and Haley, we did an umbrella systematic review looking at long COVID and these treatable traits and some of the conditions which are... So I'm just having a... Oh, there we go. These can be grouped into different... Basically, these can be grouped into different systems, if you like, respiratory, cardiac, etc. A treatable trait approach... I'll go back just to, if anyone wants to get that. But a treatable trait is defined as having three things. It needs to be identifiable or measurable, it needs to be clinically relevant, and it needs to have a treatment that's available for it. And so this approach then allows us to do something about this complex chronic condition, which affects many organs. So in terms of a management and prevention, we want to diagnose acute COVID, and we can do that with testing, of course, with PCR testing, which is not freely available and not easily accessible these days either. So I commonly give request forms to my chronic care patients with other problems so that they can test if they're unwell. Mitigation by antivirals to mitigate against severe disease, and that's been shown to reduce long COVID, as has vaccination, of course. And then there's some interesting data from some clinical trials more recently looking at metformin, for example, was given as a randomised controlled trial, 14 days of 500 milligrams twice per day in the acute setting to reduce the incidence of long COVID. And then there is also some evidence for respiratory muscle training, there's some evidence for rehabilitation, and also some evidence for multidisciplinary case management. Some slides about respiratory and some of the pathologies that we see commonly in these patients. We often see their lung function as being normal when it is tested. Sometimes you can get this organising pneumonia that needs steroids to treat. In the post-acute period of time. We see there's increased risk of infections with bacterial, fungal and other infections. There's some data about this in the acute setting, much less in the post-acute long COVID space. Venous thromboembolic disease is also seen in the acute phase, but we commonly see this in our long COVID population. And just as an example, in evaluating breathlessness, it's good to have an approach to do that. And the approach that I would take is looking at those life-threatening conditions, important conditions, and then the annoying conditions, maybe in that order. And in that way, we do identify lots of our patients that have subsegmental mismatch defects on VQ scanning that are not found on CT pulmonary angiography. And we see these patients get better with anticoagulating them, as you would expect. We see a lot of myocarditis and pericarditis when it's looked for. And we also see a lot of anxiety and panic disorder and the interplay with that and small airway dysfunction, asthma, dysfunctional breathing. The chest pain is really interesting. Sometimes it can be because of pathology such as PE. Often it's not. And, we see sort of pleuritis and we see a neuropathic type syndrome in these patients with presumably nerve injury as the potential cause of their pain. Cough's really common, and just a couple of pictures here of obviously a spirometer and an oscillometer. Oscillometer's sort of a new device that's being used by many respiratory physicians for asthma, and it's pretty commonly used in paediatric populations. Very simple to perform. And what we see in our data, this is from my fellow looking at our data over the past 3 years, and we see those that have abnormal oscillometry that were put on an inhaled steroid. So this isn't a randomized study, this is just looking at those that had objective evidence of small airway dysfunction as measured by sound waves on oscillometry. Takes about sort of 15 minutes to do. And those that were placed on inhaled corticosteroids were much more likely to have an improvement over a 6-month period of time compared to those that did not have measurable small airway dysfunction by oscillometry. So this is all sort of, just hot off the press data, but really interesting that that's the case. Not entirely unexpected, because we see many viruses like RSV and others that cause sort of an asthma-like syndrome essentially post-infection, and that seems to be what's happening here in some patients. Not sure how we're going for time. But if we've got time, I've just got an example. This is not an uncommon situation. This was an actual patient that I've seen. She's a 48-year-old school teacher. She tested positive for COVID in January of 2022 on a PCR. She had 3 prior vaccinations, and she was referred at 4 months by her GP because she had these terrible symptoms that were ongoing. Pretty classical: sore throat, aches and pains, cough, breathlessness, chest pain. I mean, just all that list basically. And this had improved a little bit with anti-inflammatories, the chest pain, and she had some slow resolution in the taste and smells problems. So she had pretty classical symptoms. There is this difference between fatigue, which is really common, and hypersomnolence. And there's a scale that's from here in Melbourne, the Epworth Sleepiness Scale that we use. And it's non-specific, but it does give you an idea of how sleepy someone is. So someone can be fatigued but not sleepy, or fatigued and sleepy. So she was both, and her Epworth was 15 out of 24, which is fairly high. So she's pretty sleepy. She's falling asleep. She can't work as a teacher. So the initial approach there was to have a look in her airway with nasoendoscopy. She had big turbinates, do some basic blood tests, do a sleep study, put her on some amphotericin for some local thrush, probably contributing a little bit to her throat symptoms, and put her on some amitriptyline for her nocturnal problems of pain and poor sleep. And then she came back a couple of months later with some improvement. She couldn't recall the first consult, and she came with a niece. And this is another challenge, that these patients do have problems of memory, and so that also represents a challenge. So it's important, if they've got a significant other, that's also very helpful. Her mood had improved, but she still had lots of problems with sleep and hypersomnolence. She had a sleep study. It didn't show sleep apnea, and she actually slept pretty well objectively on the sleep study, and so for that reason I gave her some armodafinil as a wakefulness agent on a private script, because she was still struggling with that hypersomnolence during the day, and she had referrals to see lots of other people, including psychologists and rehabilitation physicians in the clinic. And she had some improvement over time, and that by 18 months she still had symptoms though. She'd seen a neurologist. She'd had terrible migraines, which are also seem to be quite common in this population, complex regional pain syndromes, and she was put on Ajovy by her neurologist, which certainly helped a lot. She still had impaired memory. She was back at work, but only working a couple of days a week, and she was put on a statin for her hypercholesterolemia. There is a randomized study called the Stronger trial, which has finished recruiting. I'm not aware of those results, but they were randomizing people to have atorvastatin or not, and looking at an outcome of cognitive improvement in those patients without hypercholesterolemia. So in this case, she had that, so that was the reason for prescribing it. By 2 years, which is the magic number that many people quote, but she was certainly much, much better, but she was not at baseline, importantly. And she was still on all those medications. She was using the armodafinil, and she was able to work. And she had a flare in her symptoms, which were very transient, with a booster, which we recommended that she have. And she was working 4 to 5 days a week, and this is at the 2-year mark. So lots of research has been done, and lots more research needs to be done. I'll just sort of plug Steve's book here that he's written on the subject, and open up to any questions.
Thanks very much for that excellent talk. Have you got any questions in the room? While you think about that, I'll start with the online questions. So any update, long COVID and kids and the way forward? We've had some chat about that already in this in this meeting. So your just thoughts on long COVID in children?
Well, it certainly happens. It's less frequent. I've got several adolescent patients that I see. One of them in particular was about 14 when he was acutely infected with COVID, and he's now sort of 3 years post that, and he's still has troubling symptoms that are really, really challenging. I think believing the diagnosis is important. The other challenging thing with this adolescent population is that they're in high school, they're doing HSC exams. It's a real problem. I mean, I've had some of my patients that were stellar students and then post-COVID were clearly not. There is a lot of work on the microbiome, and the microbiome seems to be something that's implicated in long COVID. Us and others have done work on this, and there's a clear difference in those that have had COVID and haven't, and those that have long COVID and don't. So there's certain populations that are overrepresented. There was a study that was done in Hong Kong that was looking at pre and probiotics that showed an improvement when taken over 6 months of a particular type, not just all coming probiotics, but a particular one. And so there is some thought to that, and we are doing some research on that. So.
Yeah, thanks. Rod Pearce, a GP, country and city practice in Adelaide. I've got a lot of patients who I think might have long COVID, but the friendly cardiologist thinks everything that's causing long COVID is related to postural orthostatic tachycardia, POTS and hypotension. So a respiratory physician is suggesting that everything might be related to their lungs and all the problems measurable in their lungs. 2 risk factors I just wonder if you can comment on, and the true believers. Social Security Centrelink don't believe in this as a diagnosis, so you put it on to say someone can't work unless they F off. And the belief in social media and conspiracy theories, to me, seems a risk factor that seems to be added to their mental health. So comments, thanks.
Well, I think in terms of a diagnosis, I mean, it is a diagnosis. It's a disability. It's beyond 3 months. It's a chronic condition. I've certainly written many letters to insurance companies and others to support, claims about chronic disability in these patients. The other thing about social media, there's certainly an association, I think. But the other thing to say is that there's a lot of these patients that are desperate, and when they're not being heard, then they look in other directions. And the topic of your thing here is about trustworthy information, and I think that's really important for us as GPs and physicians to give evidence-based and sound information about what we believe is going on, and believing our patients. I think if they're telling us that they've got these symptoms, who are we to deny them? A lot of the problem I think is that, as I mentioned, that oftentimes the standard investigations that we're doing come back as normal, and so that's interpreted. It may be interpreted by a cardiologist to say your transthoracic echo, ECG, stress test is normal, therefore you're normal, but the symptoms are not. Their symptoms are there and they're still being experienced, and I think there's a problem with our tools sometimes, and that's why I sort of point to the spirometry and oscillometry. Anecdotally, there's maybe 10% or less of respiratory physicians that would be using oscillometry, but there's good data on it for other conditions, and we're seeing here signals that it's actually useful for picking up the problem of small airway dysfunction.
Thanks, terrific talk. I was going to pick up on the support for time off work as well. We had a group of healthcare workers who were infected at work with long COVID, and they were given time off and a graded return to work as part of workers' compensation. But in the clinic, we also had people who didn't have an occupational exposure, and it's been very difficult to support them with a graded return to work. What's your approach? And how many white lies do you need to tell?
Well, what I would do is I like objective data, and so or semi-objective, and so like the Yorkshire COVID-19 questionnaire is a useful, validated tool that allows you to look at how the person is evaluating their symptoms, which are now and compared to before. I think sometimes the return to work plans can be overly ambitious from those not familiar with long COVID. I think it's important to get what the patient expectation is, and it can go either way. There's patients that I think, want to get back to work too early for the sort of work that they're doing. And there's others that maybe seem to be wanting to get back to work a lot later than what you would expect, and there's sometimes somewhere in the middle. So I think, like we know from our data and others, that there is a recovery over a period of a year, and it tends to be up and down and progressive. But in the data, for example, on mild cognitive impairment, community-acquired population COG state exam, that persists for a year. So there is, and it very much depends on what the person's tasks are for that cognitive impairment and how that's going to affect them. So my approach is to have a discussion with the patient, have a look at what I'm finding, and then say, look, I would expect that this person would have some degree of improvement over this extended period of time, but I do not know, and my next evaluation of this person is this date. Yeah.
Thank you. That was a terrific talk. I was wondering, given all your experience, would you recommend that the eligibility criteria for Paxlovid and for metformin in the acute setting should be expanded? And if so, who to, any of those people listed in those high-risk categories? And also, do you recommend for an acute illness of COVID that people sort of rest for longer than 5 to 7 days and then return to work in order to reduce that risk of long COVID?
Yeah, they're really good questions. I think in terms of PBS prescribing and lowering age, that's going to be informed by, and we've had that discussion in one of the other presentations about the strength of the evidence and making those arguments. And unfortunately, I don't think the evidence is there because the studies haven't been done that evaluate those secondary outcomes. The primary outcomes are hospitalisation and death, and that's not happening. So you don't need to prescribe it. But as we know, the secondary outcomes of long COVID is significant. And for those reasons, there's certainly an argument for it. I mean, my approach is that I would look at the prescribing criteria because they're constantly changing. For example, if someone's had admission to hospital with one previous episode of COVID, they're eligible. So there are those sort of things that you could look at, and if all else fails, a private script. The other thing to say about Paxlovid, I guess, is that there's probably some reducing efficacy over time, and in some patients, and there is data to support this, that remdesivir intravenously is probably better. And so if there's the capacity and the willingness to use that for a high-risk patient, I would have a lower threshold for bringing a patient in, giving them 3 days of IV remdesivir, even if they don't have hypoxic respiratory failure, if they're at a high risk of long COVID for other comorbid condition reasons. And then in terms of metformin, I mean, I think a private script and 2 weeks of metformin is a reasonable thing to do. The other thing to say just briefly, I guess, is nausea and vomiting. With both of those things can happen. It can also happen with the virus, and just being, in terms of prescribing, aware of those things.
And the long recovery?
The rest. Look, I think it's sensible to rest in some way, but some people will take that to the extreme and not move for a long time, and that will also predispose to DVT, PE, etc. So I think, God forbid using the term graded exercise program, but something like resting and recovery is important, and tailoring it to the individual and what they're usually doing. Like oftentimes there's expectation from 25-year-old athletes on getting back to, what they were doing, 3 days later, and probably that's not the best thing to do, having just had acute COVID. Yeah.
Right, final question down here from John.
Thanks, that was great, Anthony. And just to give a plug to Stephen's book, what's really useful, it's a form, it's only about $25, but it actually takes you through each of the symptoms. So there's a chapter on all of it, so it elaborates on a lot of things you've talked about. And he does give a brief summary of that in the 2 podcasts that he's done, which is going to be hosted on the Coracle website at some stage. And I think, as I was mentioning to you, that's now open access, so that means if patients want to watch it, that'd be really helpful, because the challenge for GPs with the long COVID clinics disappearing is the brunt falls on them, and they're all busy, And while they're used to doing multidisciplinary care, any other sort of pragmatic tips in terms of how to access care plans, how to negotiate with work cover, they've had experience of doing that. So, I just sort of give a plug for those resources.
No, and we'll definitely be adding your resource to our website for St Vincent's. And I think the discussion about, one of the messages about considering long COVID and those downstream sequelae of that patient that has the acute diagnosis now, because it's often not. And the many patients that I see 2-3 months later that actually were PBS eligible for antivirals but did not get them because their prescriber or GP thought that they were fine and they were at low risk of needing hospitalisation.
Yeah. And just if I have an ulterior motive, all of these long COVID patients have younger cousins, nephews and nieces that will see them and will not want to get that. And so that may be an incentive to consider getting a COVID vaccine booster. They're not worried about getting COVID, but if someone's going to have 2 years out of their life as a young person, that may be an incentive to say, let's get a vaccine, let's do practical things to minimise our risk of actually getting COVID.
Completely. I mean, this is all a problem for someone else until it's a problem for you when you're a young person. Yeah.
Excellent. Thank you very much for a great talk and engaging discussion. We could keep going, but